pediatric age group. Is this working? Sorry, let's try to clear this. Yeah, thank you. Okay, so as far as the neonate is concerned, ECMO has become the standard of care for neonatal respiratory failure, at least, and that's how the ECMO success story has started, with the mechanism aspiration being the commonest indication and the best outcome when ECMO was started. But more and more these days, mechanism aspiration has become less common, and the mechanism aspiration being managed without ECMO because intensive care treatment has got better with the invention of nitric oxide and high frequency oscillatory ventilation. So if you look at the recent trends, the more babies put on ECMO because of congenital diaphragmatic hernias. So if you look at this is ELSO registry data, most of the cases are described in neonatal respiratory. That's mainly mechanism aspiration, which was a very good outcome. So if you look at the total number of respiratory cases done all over the world, they're actually coming down because the intensive care got better, the indications are changing slightly. The adult number is becoming more and more of late since 2009. And out of the neonatal cases, mechanism aspiration is the best one, has a good outcome. So if anybody wants to try out ECMO, if you have a mechanism aspiration, that would be the case to try to get a success. Because the success rate is displayed almost 94%. And the best centers, they usually, they are in a pulmonary hypertension, all get better in 3 to 4 days time, and by 5 to 7 days, you can come out of ECMO with a good outcome. So if you look at the total number, it's the one in the blue is was majority, then is getting smaller and smaller. In congenital diaphragmatic hernia seems to be the more commonest indication these days, followed by the persistent pulmonary hypertension or fetal circulation. This is because in the past, congenital diaphragmatic hernia was a contraindication to go on ECMO, because it's thought that they were, all the congenital diaphragmatic hernias have some degree of pulmonary hyperplasia. So they thought they will not do better anyway, even if you put them in an ECMO. So they used to be rejected in the past, but recently they've been trying on ECMO first, stabilization, then go for surgery now. The same thing, the good outcome with mechanism aspiration. And the outcome, these outcome changes have not changed over a period of time since 1980s to until now. There's not major change in the outcome results if you look at each particular diagnosis. If you look at the mode of ECMO, veno-arterial mode is the predominant mode. That's mainly again because when the ECMO was started, it started from the cardiac surgeon, and the veno-arterial mode was more familiar, and then everybody by default they used to put on veno-arterial mode of ECMO. And recently when the veno-venous mode become more successful, that's when it's becoming more popular. And I can recollect when I worked in Leicester in a different center, Leicester used to do the veno-venous mode, but other centers used to do veno-arterial mode. And as for the Indian circumstances is concerned, at our center, though it's a respiratory indication, we still go on veno-arterial mode, mainly because we do not have a cannulas for the veno-venous mode. Unlike in adults and the bigger children, we cannot go for a 2 cannula, like one in the internal jugular, one in the femoral neonates, because femoral vessels are not developed yet for a cannulation purpose. So we cannot use the femoral vessels. So we still go for the veno-arterial with internal jugular being the venous, the drainage mode, and the carotid artery is the written cannula. The one you've seen, abellant cannulas, double and single cannula, if they become available, then we can try those things in future. If you come to children, and in neonates we discussed already, there's been a randomized controlled trial done to say that ECMO has become the standard of care. But in children, there's no RCTs being done, mainly because the number is not that big. And even to do a study is not going to be feasible once it's already established in children, and to do the same thing in neonates, is to do the same thing in children is going to be difficult. But however, there's been a retrospective studies have been done looking at the outcome who children went on ECMO, who didn't go on ECMO, and definitely it has been shown that if you initiate ECMO early enough, the outcome is very good. So if you look at come to the pediatric numbers, it's around 58% in respiratory and 50% in cardiac. So that's to discharge into the hospital. So pediatric number also going up slowly year by year. And the children, the more change in the children's thing as the conditions which thought to be relatively contraindicated, they've been considered for ECMO these days. Like for example, a child with Down syndrome. In the past, they never used to have any cardiac surgeries and never considered for the ECMO if they needed. And the children with the malignancies, they consider it to be, like I said, even to consider a ventilation malignancy, there used to be a lot of resistance. Now things have changed. So if you look at the recent ECMO data, it's all the children who have comorbidities rather than the children with normal children having some ARDS kind of thing. It's the children with comorbidities constitute the significant proportion now. So these changes, things will, as we're getting better and better, probably it will change over a period of time. So again, if you look at the number, so see, one of the things is this a blue bit which is other, which not fit into these groups, have been constituting more. So now ELSO is working on to looking at the ICD codes and dividing out as per the ICD codes. And if you look at the outcome measures, aspiration pneumonia has good outcome followed by viral pneumonia, but overall is around 50 to 60%. But this outcome also has not changed over a period of time. It's more or less remain the same. Again, in children, the predominant is still the veno-arterial mode. It's again coming from the neonatal thing. So it's in the past used to be the veno-arterial mode. And the veno-venous mode is getting better and better as the cannulas are available, and more people are realizing veno-venous is more advantageous compared to the veno-arterial mode. I want to share one of my experience here. Recently, last year we had a 3-year-old child around 14 kilos came for ARDS. We put an ECMO. So we don't generally consider non-walking children for femoral vessels, because children who are not walking, the femoral vessels are not developed very well for a cannulation purpose. So this child we thought we'll do with veno-venous mode. So we put a drainage called the femoral vein and the return into internal nuclear, but we couldn't get enough venous return. Then we changed to veno-arterial mode and we cannulated the carotid artery. And then with that we could stabilize the ECMO flows, but child didn't improve for almost, this child was on ECMO for 2 months. So we went on for a month and there was no change in the improvement in the lung condition. So we still had to continue the veno-arterial mode, but at that point I'm worried more about the artery. Now the cannula sitting in the common carotid artery for a month, my worry is that the tissue around it gets macerated and it gives up, and that's going to be catastrophic. It could happen anytime in the middle of the night also. So we electively changed to veno-venous mode, but this time we went for surgical exploration to the other side of the femoral vessels. And luckily we could get when we opened it and we could see that when we did initially, we did a Seldinger technique. It's kind of a blind, we didn't know how big we can go the cannulas was, but when we opened up, we can see we can actually put a bigger cannula. So we explored other side of the femoral vein and put a bigger cannula, and then we could change it to veno-venous mode. So you just need to be aware of these things and be ready to change. So veno-venous mode is preferred if you have an avalanche cannula. So how do you select these patients? That was we discussed yesterday. So what point you think of putting on ECMO in a pediatric patient on ARDS? So if somebody has a sustained PF ratio less than 60 to 80 or oxygen index more than 40. So when you reach this stage, they definitely should consider, but my advice would be, even before you're coming to that stage, even if you're approaching them, think about ECMO. Even the patient doesn't go on ECMO, that's okay. But think about ECMO and get in touch with the ECMO center. Because if somebody has an oxygen index more than 25 for 6 to 8 hours, that itself is going to cause more damage. So don't wait for oxygen index to reach up to 40. these, like you can say, absolute criteria, and you need to look at how fast the child is deteriorating. And as a treating physician, you have to sit at the bedside and assess how the child is going to progress. Even at that point, he doesn't need ECMO. And there's some contraindications. If somebody has lethal chromosomal abnormalities, like trisomy 13 or 18, not 21. Down syndrome used to be a contraindication, but these days it's not a contraindication. But trisomy 13 and 18 is still a contraindication because they won't survive beyond 2-3 years, even if you don't have any infections or ARDS kind of thing. If somebody has a severe neurological compromise like intracranial hemorrhage or mass effect, or somebody in the bone marrow transplant with pulmonary infiltrate, or somebody with incurable malignancy. So basically, the contraindication would be if the pathology is reversible, don't consider it. There are some related contraindications, like if a birth weight is less than 1.6 kilos or less than 34 weeks. Birth weight 1.6 kilos mainly because we do not have a smaller enough cannulas as of now yet to cannulate a child of less than 1.6 kilos to run ECMO circuit. That may change in the future. Let's see. A gestation is less than 34 weeks, mainly because they had a very high risk of intracranial bleed with anticoagulation. Duration of mechanical ventilation more than 14 days. Again, as Sunil sir mentioned day for yesterday, it is a high pressure ventilation, not the low pressure ventilation. For high pressure ventilation more than 14 days, that means by then already pulmonary fibrosis sets in, and even if you initiate ECMO, you may not be able to wean off from ECMO. Somebody has a recent neurosurgical procedure within the last 1 to 7 days, and then you need to discuss with the neurosurgeons to discuss the chances of what is the rebleed if you're going to anticoagulate this patient. And somebody has pre-existing chronic illness with poor long-term prognosis, we need to discuss with the family what their expectations are out of this. And there's another discussion about when do you consider ECMO in sepsis. Surviving sepsis guidelines, what it says is basically, if you have a persistent lactate more than 5 or a mixed venous saturation less than 55%, even with a reasonable cardiac index of 2.1, or a severe ventricular dysfunction, or a inotrope score more than 50, or is more than 45 for 8 hours, then you should think of ECMO in these situations. Some of the conditions, but peculiar to the pediatric population, is if somebody has a tracheal stenosis, injury to tracheobronchial tree. So if you want to repair, then you can go on ECMO and then you can repair easily. Some children with mediastinal mass. One patient I can recollect when I started in Hyderabad 5 years ago, we had a 12-year-old boy with a lymphoma diagnosed, compressing in the trachea. Then he presented with severe respiratory distress, and he was in tripod position and trying to maintain his airway. At that point, we didn't start ECMO at that point. Then he arrested, went into respiratory failure and arrested, and we couldn't intubate him. Because I could go to the glottis, but it won't go beyond that because it is narrowing down below. Trachea was compressed. So we lost that child. But in those situations, if you can, child almost stayed for with a day. If you had ECMO and then you initiate ECMO even before you arrested, there's a good chance that he could have been survived. And these lymphomas are very sensitive to steroids. If you can give steroids for at least for a few days, that melts the mass. And pertussis in children, this is one of the bad outcomes you get on ECMO, pertussis and pneumocystis as well. Especially, in South Africa, they do ECMO on HIV patients. So HIV itself is not a contraindication. So what they do is sometimes rather than going on ventilation, when they think that they're going to get worse, try non-invasive and go on to straight away on ECMO rather than trying for invasive ventilation. And sometimes vasculitis and autoimmune lung conditions. I had one girl with 12-year-old presented with ANCA-associated pulmonary renal syndrome with massive hemoptysis. But she was not diagnosed at that point. She presented with massive hemoptysis, and then we went on ECMO, and then later on we diagnosed, and we did plasmapheresis on her, 5 sessions plasmapheresis, followed by the steroids. But problem what she had was on the day 7 when her lungs are improving, she went into full-blown sepsis and went into full vasodilatory shock. And then we had to do resuscitation, CPR, and then change to veno-venous mode to veno-arterial mode, and then give sensitive antibiotic and change the antibiotic strategy. She improved, and almost that took almost 3 weeks. But she did come out of that ECMO and recovered completely. Now recently she gave her matriculation exam as well. Sometimes we're not sure with this condition if it would qualify ECMO or not. If you're in doubt, call up these experts, or you can contact ELSO as well, or go through the website to see for any patients have been put on ECMO for this kind of conditions and what is the outcomes. We come to special consideration for neonates. What we tend to do is go on ECMO flow slowly, as they do not have a very good cerebral auto-regulation. So to prevent any cerebral hypoxemia, so go on ECMO flows very gradually. And even if it's a mechanism aspiration with cardiogenic shock, even very high inotrope, try with the veno-venous mode if a feasible thing, first of all, because once you provide the good oxygenation, heart function improves, because their hearts have been normal hearts until that point of the time. So they're not had what adults had coronary issues or anything. So if once you oxygenate them, they tend to come and the function team come back to normal. And we tend to, once we go on ECMO, we tend to start feeds earlier on, because nutrition is one of the important components in pediatrics. Unlike adults where you can probably wait for 2-3 days fasting, that can be detrimental in pediatrics. Coming to pediatrics age group as such, so children who are not walking, femoral cannulation is going to be difficult. So you need to have a strategy how we're going to do it. So generally in those situations, we use carotid artery to return the plate into the veno-arterial mode. And after, when the patient comes off, depending on surgeon comfortable, either he can repair the artery or he can ligate the artery. And usually we use a blood priming for all the pediatric age group, because the circuit volume itself is significant if you compare to the blood volume of the child. So we tend to use blood priming in pediatrics. So well, if I get a call for the ECMO, one of the first thing I ask for is a reservoir unit of blood, because that takes its own time. And if a child is more than 20 kilos, we generally tend to go for adult circuit, because if you need more than 2 liters per minute of flow, pediatric circuit is going to be really difficult to achieve that. Again, oxygenators are the different sizes for the pediatrics and the neonatal. And the pumps, if you go to Meadows or Mackey, the pump is the same for pediatric, neonatal, or adults. But the one we have here is a slightly different one. The different sizes are there. So sometimes, as we mentioned, discussed yesterday, apneic ventilation. If somebody goes on ECMO for ARDS and the lungs become completely solidified, we may not be able to detect any tidal volumes. Even though you're giving, however the pressures, you give how much of the pressures, we still not be able to get any tidal volumes. So don't get too much worried if you don't see any tidal volumes on the ventilator, and if it says apnea, just wait and see. It will improve over a period of time. And consider early enteric feeds. Sometimes we use transpyloric feeds if you think of reflux is the issue. And they need to think about sedation if you are doing any invasive procedures. And all these things, children, especially who goes on veno-arterial mode, they need long-term neurodevelopmental follow-up. Just how they are going to develop, and they might need some early intervention strategies. So you know, a patient to an awake ECMO, extubated on ECMO. Right, that's about it. Thank you very much for your attention.